Hello, and a very warm welcome to our Congress coverage from ASCO. ASCO, as many of you know, stands for the American Society of Clinical Oncology, and I would say it's one of the largest cancer congresses in the world. Sherko, Kümmel, and I have selected a few interesting studies that we would like to discuss. And first of all, of course, I would say, Sherko, why don't you briefly introduce yourself? My name is Alexandra von Korff from Patients Today. Please.
My name is Sherko Kümmel, and I'm a gynecologist by training. However, I specialized almost 20 years ago to focus exclusively on breast cancer, covering everything from surgical therapy to systemic therapy. For this reason, I also head the breast center at the Essen Clinics, which is part of a very, very large women's cancer center, practically in the west of the country.
Yes, we are, of course, very happy that you always take the time. This is a collaboration with Patients Today and Mamma Mia. And we are pleased that we have already been able to present this many times. And now we are very excited about the latest studies that you will present to us first, Sherko.
And I really brought something with me that might actually change practice a little bit. So there are a few things included, so it might be worth sticking around. As always, I'll try to explain it well so that you can take something away from it and become more knowledgeable. Maybe you won't understand every single curve and might say, well, I'm not exactly sure about that part. What's important for you is that you take something away and say, hey, I'll ask about that again. In my opinion, that's always the most important thing. You don't have to understand every tiny detail. You just need to think, hey, this could affect me, so I'll take a closer look at that. Or maybe ask again at my clinic or with my gynecologist, so to speak.
Yes, of course, it's also important that you always explain all the terms very thoroughly. But if there are still any questions, we have a glossary on Patients Today where you can look things up.
Yes, so just to provide a disclaimer for all of this and my disclosures in all of this regarding early stage breast cancer. And we'll start, I would say, right away with what was the highlight for me in all of this. And usually our highlights are always the new chemo, the new thing, or the additional treatment. What was the highlight for me? That we're actually doing less overall. And that's why, so to speak, this is all about avoiding chemotherapy for once. So this is a topic that I've been advocating for years, so to speak. Many people know that I've been promoting this across the country. Dynamic Key 67, ADAPT studies, and so on. And now, a study by colleagues from the United Kingdom, so from the UK, has been presented, focusing on hormone-dependent breast cancer. Of course, that's what it's about. That is endocrine therapy in certain situations just as effective as chemo plus endocrine therapy? So endocrine therapy? Exactly. What might have been different here, so to speak, is that these colleagues who, for the first time, apart from the West German study group, dared to do this, looked at patients with 0 to 9 lymph nodes. That means, as we know, starting from 4 lymph nodes, chemotherapy is always recommended. We started conducting the first studies several years back in the past, saying that if we have an endocrine response in the broader clinical context, and a low risk according to genomic assays, then perhaps there is no significant additional benefit to be gained from chemotherapy. We're still waiting for the data on that. So genomic testing with a low result and hormone-dependent tumors in combination. Exactly, that's the overall idea. And that's what they dared to do here. And they included women where the question always arises, premenopausal patients, positive lymph nodes, do I always actually need chemotherapy in those cases? No matter what the oncotype, MammaPrint, or any other test says. So to sum up, very, very exciting data in this situation. What was done? More than 4,000 patients were included, hormone-dependent breast cancer, no distant metastases. 1-to-1, randomized. If, in this specific situation, chemotherapy was clearly indicated, but the genomic test, here it was Prosigna, showed that it was a low-risk profile, then it is quite possible that chemotherapy wasn't actually needed after all. So randomized against chemotherapy, this is called the ROR score, if it is less than 60. You don't really need to remember that for now. Follow-up. The follow-up period is still a bit short at this stage, but it already provides us with valuable insights for our daily clinical routine. The main question, the primary endpoint, was fundamentally defined as cancer-free survival, which refers to the fact that no invasive breast cancer had returned as distant metastasis or local recurrence. Let's take a look. 2,000 patients with chemo, 2,000 patients without chemo, when the Prosigna test indicated low risk. But there was actually an indication for chemo in that situation. Now let's take a look at that. That's why curves are always better than individual tables. And when we look at the curves, we ask ourselves, what color did they use? It's basically identical throughout. That means the patients who didn't have chemo had the same survival as those who did have chemo. This means that if the genomic SCM indicates a low risk, then these particular patients do not typically benefit from chemotherapy. That is the interpretation of those curves. Then it happened. For the first time, people said, well, that can't be right. For premenopausal patients, we must give chemo if there's a positive lymph node. All the studies have shown that. No, that is not the case. And what was the crucial thing that our English colleagues did? They intensified endocrine therapy. They made the treatment significantly more intensive and did it quite differently. They gave all patients who were still premenopausal, that is before the onset of menopause, an additional GnRH injection, such as enantone or trenantone. This means ovarian suppression or the reduction of ovarian function, and that seems to be the trick, the essential key to the entire process. If I do that, so to speak, plus anti-hormone therapy in this specific constellation, then I'm probably every bit as effective as traditional chemotherapy. And of course, for postmenopausal women, we already had a lot of data, of course, not with multiple lymph nodes. Now comes the conclusion, and that's why, once again, a word of caution. Don't all go running out tomorrow saying, I don't need chemo anymore, and so on. Now we need to be precise about the situation. What did this study with 4,000 patients change for us again on Monday? So to speak, first of all. We now have even more certainty that patients with lymph node involvement, let's say 1 to 3 lymph nodes who are postmenopausal and have a low-risk profile in the vast majority of cases, can really forgo chemotherapy. So we need to use the genomic tests, Oncotype, MammaPrint, or now here Prosigna in this situation. Second point. If I now have premenopausal patients and provide them with adequate anti-hormone therapy, 1 positive lymph node, genomic test low, risk. And I always add dynamic Q, 66, meaning the response, these 3 or 4 weeks before the operation is, in my opinion, especially important to do. This anti-hormone therapy during the 3 or 4 weeks before the operation. And when these factors come together, even with positive lymph nodes, you can now discuss with the patient that although chemotherapy is still included in the guidelines, the benefit of chemotherapy will probably be less than 1%. So this is extremely, extremely important. This is how you have to analyze the data, and this is how you can now incorporate it. Final point. The question is, I have 5 lymph nodes. According to the study, I also don't need chemotherapy anymore if all of this applies. We're not quite there yet. As of right now, regarding the 5-year follow-up study, we have only collected information on a relatively small group of individuals, specifically just under 200 patients who have been observed for that full period of time. For me, starting from 4 lymph nodes, there is still an indication for chemotherapy as of Monday. However, we can tell patients, for example, if we have a test, which it must be said is not on label, because according to the guidelines, chemotherapy is still indicated from 4 lymph nodes onward, that we know the effect of chemotherapy is smaller, the prognosis for the patient is very good, but it remains, currently there is still a recommendation for chemotherapy. So in a way, you can summarize the data in a way that is, I believe, very understandable.
You explained that really well. Thank you very much, because I think it's often the case that people say, okay, I actually don't want to do chemo. But if it affects my risk, I mean, I don't want to proactively go and say, no, I'm not going to do it if that would reduce my chances of survival. And these data really show very clearly that if you follow exactly that approach, you can truly leave it out with a clear conscience. That's wonderful. So thank you very much for that.
So starting Monday, to summarize again, according to the current data, what I consider standard and what we do for every patient at our center is to begin anti-hormonal therapy for hormone-dependent early breast cancer. I would say, depending. So premenopausal or postmenopausal, plan surgery 2 to 4 weeks afterwards. For dynamic Ki-67, if the level, previously over 20 or 30%, drops below 10%. If there is a question of chemo, I can perform Oncotype, MammaPrint, or Prosigna on this first biopsy. So then, after the operation, I have the fully complete picture. Let me put it this way. What I mean is, I have the basket of information to be able to discuss things in detail, to say, I don't need chemo, or if I do recommend chemo, the benefit is such and such. That means the patient can also assess what benefit she's actually getting from this, so that we also move away from statements like, if you don't do chemo, then you will die. That's complete nonsense. Let me just say it like this. That simply doesn't exist.
That's shared decision-making in practice.
This is what shared decision-making looks like in practice. And of course, if someone says, I don't want to know the percentages or how much benefit it has, I want to know for myself, what would you do? Then I also answer very clearly what I would do with my own family. All right, let's continue. So next study. So now we've basically looked at the therapies in this situation. We have the NATALEE study, which you all know. That means the NATALEE study led to us for hormone-dependent tumors, whether chemotherapy was given beforehand or not, if we add ribociclib to anti-hormone therapy for 3 years. So always with aromatase, always for premenopausal patients with ovarian function suppression, for postmenopausal patients, always aromatase and ribociclib. What has been done now is that the patients have been genetically classified again, not genetically, not like Angelina Jolie, meaning whether they have a BRCA mutation, but genetically, what kind of tumor is it? These are then called luminal tumors, HER2-enriched basal-like. This is a kind of genomic genetic tumor classification. They looked at it and found that over 80% are called luminal A and B among the hormone-dependent ones. And the others are small groups. And they examined whether the CDK4/6 inhibitor, for example, is not effective in basal-like tumors. Because basal-like is similar to triple negative or other signatures when viewed as a genomic type in all of this, that was the background of this NATALEE study, which I just explained to you. What role does possible tumor genetics play here? Or do I need to determine tumor genetics in order to say whether the patient needs it or not? That's an important question. That's exactly what was examined. The endpoints were analyzed again with this in mind. We already know them because that's what led to the approval. In the overall situation, let me show you the curves. First, you have to look at whether the patients for whom the biomarker analysis was done are, so to speak, representative of the overall analysis. The curves are identical, yes? So the specific patients are identical in the cases where this was done. Now, this is again one of those, how should I put it? Let me summarize it for you. Just download everything now. Yes, in the whole context. So whether I have luminal A tumors, basal-like tumors, HER2-enriched luminal B, the ribociclib almost always helps in the whole context. In other words, I don't need to do this classification to decide whether I need ribociclib. In the whole context, that's the next interpretation in this situation. That's basically how you can summarize this data. Ms. Picard summarized it well again in her discussion that for many of these things where we're looking for biomarkers, it's justified to ask who needs it and who doesn't. But in the early disease setting, we haven't found a biomarker for many things so far. That's also important to mention again in the summary. So in other words, my conclusion is that this study does not change anything in our daily treatment routine. Currently, there is no biomarker in the blood or tissue that can show us for which patient we should recommend or omit ribociclib. Therefore, for all patients with medium or high-risk potential, according to the respective approval, CDK4/6 inhibitors, that is, the blockers, should be used as standard therapy together with endocrine therapy, because they are effective regardless of whether Ki-67 is high or low, etc., and so on. This is also something I find very important to emphasize in the discussion regarding the use, because we see, and this is a bit unfortunate, we see that the survival benefit is indeed significant, but it's a shame that a number of patients are not even being recommended this therapy.
So that means proactively asking, what about a CDK4/6 inhibitor, specifically ribociclib, and, since I don't have it yet, the anti-hormone therapy in combination?
Similarly, if I have multiple lymph nodes affected, so simply CDK4/6, and then there's also abemaciclib. If many lymph nodes are involved with a lot of very good data, or with 1 to 3 lymph nodes affected, if G3 is also present or the tumor was very large, over 5 centimeters, then the indication is to add abemaciclib for 2 years. And I have to say, based on the data, unfortunately, if you look at the real world, a number of patients are not actually being recommended this treatment. And that's perhaps a shame.
So just ask about it on Monday. Exactly. I've carefully explored all the possibilities, so let's go ahead with it.
Right, as you said, for me, it's been 6 months since I just finished radiation therapy. You could also start after 12 months. Up until then, it is still approved. If you say, well, yes, that's true, you actually have a right to be informed about this. Additionally, of course, there's an escalation, meaning side effects are also part of the whole process. But it's not like my surgery was 3 months ago, so now I can't get it anymore. No, that's not true.
Thank you very much. Although I have to say, regarding the CDK4/6 inhibitors, I do hear quite often that the side effects aren't actually that severe. But you can probably speak better about that from practical experience.
We often do it in a very sequential manner. We start with anti-hormone therapy, which isn't easy in this situation. And when we add the CDK4/6 on top, we often don't see much additional strain on the heart. And that's why I actually love sequential therapy. If we're going to do something like this over 5 years anyway, we don't lose anything at all. So maybe 1, 2, or 3 months of anti-hormone therapy. The standard, see how it goes, how it settles in, and then add the CDK4/6 on top. Great. So that's my routine. Yes.
That sounds good. If I recall correctly, you're typically an advocate of gradual dose escalation to ensure better patient tolerability.
One valuable lesson I have learned from my children is that with a wide variety of different allergies, if I just gradually titrate the dose in, I can successfully avoid many of those allergic reactions. That goes for medications and other things as well. So why shouldn't we try turning that around in oncology as well? And say we often have this issue with dosage questions, especially with medications that cause diarrhea. If we gradually increase the dose, we're often more successful.
Great, thank you. So let's take a look at the next study.
So let's keep going, so to speak. We've brought you 7 again. That means more than usual. That means you have to stay tuned. You definitely have to watch this because you'll always learn something new.
But we also have jump markers, so you can just skip a study if you want, but this one fits thematically quite well again, because we are discussing anti-hormone therapy once again.
You are in a group with other women. Now, if you say, I have triple negative, so I don't need to listen to this, but maybe someone sitting next to you has hormone-dependent cancer, then you can say, have you heard about the new medication that's likely to be approved in the next few months? No, what is that? Giredestrant. That means we need to talk about SERT. I've explained SERTs in great detail in the video about metastasis. You can also take another look there to see what SERTs are, this degrader function, etc. Regarding the receptor, today's new anti-hormone therapy is replacing tamoxifen and aromatase inhibitors, such as anastrozole or letrozole. A brief summary, yes, in this situation. So we've known this since San Antonio, where the data was presented in its entirety. What did Peter Schmidt show again at ASCO? They showed individual subgroups again from the lidERA study. That means several thousand patients were examined here. Classic hormone therapy, whether with chemotherapy or without for 5 years, or the new therapy with the so-called SERT in all of this, that is chiroraidistrant, the new medication. You see several thousand patients in all of this with standard of care, so to speak, or this new medication. Endpoints, just as usual, this invasive disease-free survival, which is internationally recognized as an endpoint to see whether a therapy is more effective. In this situation, number of patients, look at this, huge patient numbers, which allow us to draw conclusions both premenopausal, before menopause, and postmenopausal. And now take a look at this. We've learned about metastasis, but Mr. Kümmel, you just explained that all of this only works in the presence of an ESR1 mutation, apparently only in a metastatic situation. If we look at the early treatment situation, since it is often said SERT only helps ESR1, only 1 to 2% of patients have an ESR1 mutation present. These benefits simply cannot be achieved there. That means in the early treatment situation, this new medication seems likely to help regardless of an ESR1 mutation. Take a look at the hazard ratios. You've now become knowledgeable from the metastatic video, thanks to me. What does that mean? So if I now, so to speak, below 1 and 1.0 minus 0.65 is 0.35. That means a 35% improvement. 0.58, let's do the math again. 1 minus 0.58 means, in other words, a 42% improvement. Sometimes medicine can be explained this simply, so to speak, in the whole context.
Thank you very much. To take a moment and explain it once more, because I really don't think our listeners or viewers who are tuning in are going to go back and rewatch the entire very detailed metastatic segment again.
And think about when he talked about statistics so that I can translate it simply. That's why I did it again, so to speak, for you. Simply put, here is the calculation. If you have 0.65, it is not obvious that it means 35%. Subtracting it from 1 gives you that 35%. Let's look at this now. Then you might say the curves, Well, what do they tell me? So first of all, clearly the good news is that most people survive the situation overall. And then in those cases where a recurrence does occur. Looking at the Bordeaux-Farman curve, there are also ways to improve things. So now the question is the effect only seen in younger patients? Or is the effect only seen in older patients? Or is it independent of age? And the important answer, it's independent of age. Both premenopausal and postmenopausal patients benefit from it. That's an important point. So to summarize the whole thing now, this essentially means that I'm performing better across the board in IDFS as well as in distant metastasis-free survival. Someone might say that only prevents local recurrences. That's also significant, but maybe not as meaningful. That's not true. Distant metastases are also highly significantly affected in this situation. The hazard ratio is the same, over 40% improvement. Well, and we've always learned, well, it must be something that's probably even less tolerable than the aromatase inhibitor. Now let's look at the bottom row, and that's not true. It's actually better tolerated than the aromatase inhibitor. If we examine the rates of treatment discontinuation due to AEs, which are adverse events, meaning, for instance, that I am having hot flashes or I am dealing with bone pain that is hard to manage. No matter that it's supposed to help me, I'm not going to continue with it anymore. In our standard therapy in the study, it's 8.5% among study patients, but with the new medication, it's only 5.7%. Significantly fewer. These are therapy discontinuations. There are significantly fewer occurrences than in our standard therapy. So we see a much higher level of clinical effectiveness, and most importantly, the primary focus, bone pain, a lower percentage and a notable reduction in the severity of bone pain for the patients. It is also likely that there are generally fewer side effects, which is why there are fewer therapy discontinuations. That is truly fantastic news. That's fantastic. That's another side effect. Of course, I have hormone-related side effects. Those are the same. I don't have arthralgia. I don't not have, yes, hot flashes. I have hot flashes. I have this fatigue and other things. But in comparison, these are the new curves where you can gradually look at the old therapy versus the new one. You see it's less pronounced. So a great result. So to sum up, it will become a new standard in this situation. Now, of course, Alex will probably ask, well, from when and how exactly? Exactly, you know me. I wanted to say what happens on Monday. Exactly, what happens on Monday? So on Monday, none of us will have access yet in general. First, it needs to be approved. That will certainly take a few more months. Then others say, well, what about me? I'm getting letrozole and ribociclib, or I'm getting letrozole and abemaciclib. What about me? That stays the same. That means we still don't have any data on whether SERT can be combined with a CDK4/6 inhibitor. We all assume that this would naturally be the next leap forward for further development. These data do not exist. And now, as is often the case, especially with hormone-dependent diseases, the West German study group is already one step ahead. That means as part of studies, specifically the ADAPT-ELA study, patients or half of the patients can receive it. Assert the ELAS cistrand and, for example, ribociclib, if you take the indications for CDK4/6. Outside of studies, they definitely will not receive it.
Now there is, which again means maybe that could also be a motivation to participate in studies precisely for such.
That's just the way it is. So I would try everything. If you ask what I would do for my family, I would try everything to get into that. I see what kind of success it has. And I also know that if 2 or 3 years after the therapy it gets approved, I will never get it again. Yes, because then it will only be the patients who are in that specific phase. Like I know 6 months after surgery, they might then get it. And then the question is, isn't CDK4/6 and letrozole perhaps even better? We would all still recommend that because, of course, we have much longer-term data. So that means you really should try to get into that.
Now, let's move on to the next question. All open phase 3 breast cancer studies are listed right there for you.
Then we'll check for ADAPT-ELA, and if not, we'll have to send you again and enroll you.
It has to be included in there. All open phase 3 studies are included. All right, then.
That's one option right after the surgery. Many centers in Germany participate in this, so be sure to ask. A second possibility, if everyone now says, well, but I've had this for a few years already, does it still help afterwards? We are going to get a group of studies that have investigated this after CDK46. Do I then have to continue taking nitrozole and anastrozole, or isn't SERT even more effective? Based on the data, it's reasonable to assume it will be more effective at this stage. Now, everyone is asking, how can I access it? Access to it? Not possible either. And that's why I'm telling you this, because there is only one single study left in Germany, which will probably continue until the end of August or the beginning of September internationally. That is the ELEGANT study. This means especially for patients who, for example, have received abemaciclib and are 2 to 5 years out from their therapy. So it could be either directly after abemaciclib or, let's say, 3 years after finishing abemaciclib. This patient population, among the patients, as we know, they need anti-hormone therapy for a longer period, and that's what the study is about. The study is called the ELEGANT study. There are various centers in Germany where, so to speak, you can receive elacestrant or the standard endocrine therapy. Apart from the study, it remains 100% the standard endocrine therapy. That still relates to the question because, of course, with the data and our patient academy, everyone is already asking me, yes, and how do I get a cert now? Then I list what is available today in different populations. It is already accessible.
Yes, great. Thank you so much for the tips.
So next practice-changing study. Now for everyone who said, yes, I listened to the part about monoreceptor positive, but for me, triple negative is important. Early breast cancer, and a study that I'm also a bit proud of because back then I even changed one of our vacations a bit with my family and convinced my family to do so. To say I have to attend that meeting, I basically have to spend the evening making sure we get this study underway and work on its design in the steering board. In all of this, in that situation, just like with surgery and everything else, there were important questions and it was worth it. Yes, it was 2016. Sometimes that's just how long it takes. And now the final analysis has taken place of the KEYNOTE-522 study. This is the study where, in addition to the chemotherapy that we have to give before surgery, we found that adding pembrolizumab before surgery is more effective, and then continuing pembrolizumab for 9 cycles afterwards. In that situation, if you operate first, you end up coming in second place overall, because then there is definitely no immunotherapy after the operation. If you haven't treated neoadjuvantly, then immunotherapy doesn't make sense. Let's take a look at what it means if you treat neoadjuvantly. You have the endpoints. Everyone is familiar with the study as a whole. And this was the final analysis that was now presented at the American Cancer Congress with overall survival. Again, at the end, just to take a look at it, I'll just show you the curves. So if I decide today to operate on a patient instead, and she doesn't receive immunotherapy, then I have this difference. Incredible. That means it's also something for you to think about. When we say we have to give chemotherapy before surgery, it's not just to shrink the tumor, or because we somehow think it's good, or for any other reason. This is a survival benefit. Anyone who goes somewhere and says, I just want to have surgery, because everyone feels that the tumor needs to be removed tomorrow so it doesn't cause any harm. That's why I'm showing you this curve. With this decision, you are making a choice that gives nearly a 10% survival benefit. 10%. That means neoadjuvant therapy and then pembrolizumab as well, if the tumor is over 2 centimeters or if there is a positive lymph node. Then this therapy is indicated. Is it exactly the same for overall survival? Take a look at this. And of course, as time goes on, the curves will continue to diverge even further. You can see it here as well. In the final analysis, here on the right is the final analysis. It shows that if you operate first and then do the chemo, you are at least that much worse off. How do you explain that? Because chemotherapy, when the tumor is still present, often actively disrupts or attacks the tumor. This naturally leads to the production of various antigens. And in doing so, I prime the immune system. And when the immune system, pembrolizumab, which I always call the rodeo horse, that means it's wild, it's strong, it kicks out like that. In all of this, it releases the brake on our immune system. That's why we sometimes have these side effects. That's why we must not forget this, that this is an excessive reaction, that I get inflammations that have nothing to do with bacteria, etc. It releases the immune brake. That means the antigens trigger it. I know what the immune system is being trained against. And I also release the brakes that the immune system has and say full power on this. And then I arrive at the result. Of course, I have to be able to deal with the side effects with this release of the brakes.
But in exchange for this, I basically have an exceptionally well-tuned immune system, which effectively helps me to survive for a significantly longer time.
That's how it is in the end, and that's why we really have to look closely. You need a lot of experience with the teams to know how to apply it. In all of this, when there is such an excessive reaction in the immune system, that's when cortisone is also used. So, and these are again the question that is always asked, if I have a PCR, do I still need immunotherapy? Yes, take a look at this. Still 3% in the situation as if I achieve a PCR through classical chemotherapy, even if I did it beforehand. I can only achieve a PCR if I administer the chemotherapy before the operation.
So, progression-free survival and a pathological complete response, meaning that after the operation, no remaining tumor cells are found anymore.
Exactly. So even with a PCR, immunotherapy still had an effect. Yes, in all of this. This is, of course, the summary of what I have already mentioned. We must not overlook side effects. And by now, I believe the centers and the teams in the outpatient clinics are very, very well trained. We have numerous different immunotherapies. For breast cancer, for example, just pembrolizumab among all of them. But we are trained to know which blood values to take, what we need to look at, etc. in order to also detect immune-related side effects early on as well. That you check the pembrolizumab levels and so on. That means my conclusion after this final analysis with significant overall survival rates, neoadjuvant and adjuvant immunotherapy with pembrolizumab is and remains the standard therapy for early triple-negative cases. Negative breast cancer patients in stages 2 and 3, like I said, from 2 centimeters or with positive lymph node status, this is how it can be summarized.
Yes, those are, of course, severe side effects. So you also have to consider that in terms of quality of life. But I think it's good because the normal reaction is always, I have a tumor, I'll just have both breasts removed, take everything out. And this, once again, reinforces the idea that it's actually better not to operate beforehand. Thank you.
Gladly. So now let's continue. For everyone who stuck it out and thought, well, now I've already gotten through all of this, great, but what is there for me? And of course, together with Alex, we found something that also applies to you, so to speak. That's the modern German term for it. Longevity. You've probably never heard of that before, just like AI. It's never been used in all of this. So actually, it's a term that comes up somewhere every day in this context. So what was done here? By cancer centers in Italy, they examined how the Mediterranean diet, what does that mean? Well, that means it's based on fruits and vegetables triggered by olive oil, so to speak, in this context. That means rich in these. Additionally, a diet high in fiber. Did they measure vitamin D levels? So to speak, they supplemented it. In other words, a Mediterranean whole food diet. And they implemented various programs with it. It would go beyond the scope to explain now what kinds of coaching and so on were involved in that situation. Let's take a look at that. So to summarize at the end, changes in lifestyle factors in this context. Vitamin D deficiency was corrected, diet was changed, and a bit more exercise was done. That's what was done. So women with breast cancer were included, regardless of whether it was hormone dependent or not, at 7 oncology centers, so to speak. Either the control group received standard counseling on the Mediterranean diet. That means they were already advised to eat better and improve their habits. And of course, they were already following a Mediterranean diet since they come from those countries. That's something you have to keep in mind. That means we can really only interpret the data we've seen in terms of what it would mean for Germany, where we don't have a Mediterranean whole food diet and where not everyone receives counseling on how they should eat. And then in the intervention group, they intensified things a bit further. And they also adjusted the vitamin D levels according to the blood values in that situation. The primary endpoints were, of course, the risk of relapse. They also monitored weight throughout the whole process in that situation. Now let's take a look at what the results were. Control group, standard Mediterranean diet plus regular advice and vitamin D. So, a Mediterranean diet plus a consistent routine of exercise and vitamin D, the study showed that overall, there was no benefit. That means if I'm already eating a Mediterranean diet and taking vitamin D, I've already taken significant steps for my health. First message. Weight loss? Yes, if I add some exercise, of course, that adds a bit more. BMI change? Yes, but it wasn't significant. But in the whole context of metabolic syndrome, what is that? So the whole picture. Obesity, diabetes, all the resulting diseases, risk situations, also for other cancers, colon cancer, endometrial cancer. Gastrointestinal issues is part of all this. So a lot of things. Metabolic syndrome involves a lot. So a low-grade inflammation in addition to obesity and everything else involved. Highly significant improvement So exercise, Mediterranean diet, vitamin D. If I intensify that a bit more, I will definitely achieve an improvement there. And now comes something astonishing. In patients with hormone-dependent breast cancer, there was indeed an improvement. Take a look at this. A significant 76% improvement in relapse-free survival achieved through consistent exercise, vitamin D, and balance. In other words, carefully maintaining a low level of balance in all of this. I personally would not say that you have to go over 60 here or anything like that. That is also exactly what the discussant said. And nutrition. So that doesn't mean you have to give up every glass of wine on Mondays or anything like that. Daily alcohol consumption is not the point anyway. But switching to a Mediterranean diet, that's something I can take a look at in this situation. Everything that has color, and it doesn't always have to be, that's basically positive. So fruits and vegetables with an emphasis on vegetables. Integrate fiber. It's not about cutting out all carbs so that insulin disappears. Nonsense. Whole grain bread in the evening, a slice of whole grain bread, so to speak. Delicious in summer with tomato, cucumber, whatever you like on top. Maybe some Parmesan on top, high calcium content, great. I'm not a nutrition specialist or consultant. Aim for 30 grams of fiber per day. Check it out using apps, enter things yourself to see what it adds up to. Maybe try changing the salad to lentils, beans, or something else like that. It takes several months to change the microbiome, but just look at the effects. I think it's pretty remarkable what you can change just by altering your lifestyle. And if you ask about sports, this isn't the study for that, but we do have other sports studies. By now, the standard recommendation in this situation is twice a week. Strength training for at least 20 minutes and 2 or 3 times a week endurance training overall.
And that in turn, to put it into perspective, of course, it's about what you can manage. For some people, it's not about running a marathon, but just tasks like successfully climbing up the stairs.
Even everyday activities are enough. For example, at Berlin Central Station, instead of standing on the escalator, you could just take the stairs for once. So just these little things in everyday life where you might say, I don't have time for that right now, or for that simply, even changing these small things. That's what lifestyle works basically means.
Yes, great. Thank you very much. I think in general, it's also good to just check. There are various apps to see where I stand with my proteins and carbohydrates and whether I'm doing everything right, you know? Is it in balance? There's actually a lot of potential for optimization always for everyone.
Now, so to speak, we are finally moving on to the very next important question in all of this situation.
Which aligns perfectly with the discussions we had earlier. Topics like anti-hormone therapy and side effects.
For the first time, we now actually have medications, medically speaking, that treat side effects besides painkillers for bone pain. Now, the question of hot flashes. We have the OASIS study for that, which we already presented to you last time. And then at ASCO, they also came and said significant hot flashes. And for everyone, the good news, L-ensanitant is the medication we're talking about here. Ideally, 2 tablets in the evening, so 120 milligrams. And then, so to speak, significant change in vasomotor symptoms, in other words, hot flashes. Highly significant. Personal experience since April 1st. It is also prescribable, approved. Don't miss it. A very important message from me right up front. If you are taking ribociclib at 400, then whether you are prescribing it or receiving a prescription, please pay attention. In that case, you should only take 1 tablet in the evening, not 2. Because the metabolic pathways of these medications use a common pathway in this situation, you need to be a bit careful. And now they have looked at whether the change in hot flashes also affects sleep quality, specifically the improvement in the OASIS-4 study. Now, of course, everyone sitting in front of the screen or watching this is probably thinking, well, obviously, if I don't have to change the bed sheets and my pajamas 3 times a night, then I'll sleep better overall. Well, let's see what the results were. Probably yes. Here is the study again, 12 weeks of placebo versus L-ensanitant. We saw that the placebo also reduced symptoms a little bit, but of course, the medication was significantly better at reducing hot flashes. And when everyone received it, the effect was also long-lasting in that situation. Was it used in different patients, aromatase inhibitors, tamoxifen, and so on, with ovarian suppression without subgroup analysis? In all of them, regardless. So it doesn't depend on that in this situation. Important, Kisqali, that is ribociclib, pay attention to this again. In that case, don't take 2 tablets, but only 1 if you are taking Kisqali at 400. And to summarize the question here, did it improve psychosocially, physically, sexually, basically in all areas? Of course, with a focus on hot flashes, because that's exactly what this medication is for, it acts centrally on the nervous system. And the top question, does it improve my sleep overall? And the overall summary is yes. So that's what we expected. So if I sweat less, have fewer hot flashes, then I also sleep better.
My whole life is simply better if I have fewer hot flashes.
In the end, you can sum it up like this. So elinzanetant not only improves hot flashes, but also sleep in breast cancer patients who suffer from these side effects due to this therapy. And it is now officially approved for these patients so that we are allowed to prescribe it.
Yes, I think it is wonderful and revolutionary because otherwise it's always like, well, you have menopausal symptoms. Tough luck. Unfortunately, there are no hormones. We can't give you anything else. So now suddenly there's an option for women who aren't allowed to take hormones. I think that's fantastic.
So I think we've brought you a potpourri here, which I believe is really great, right? It's fantastic. And on the one hand, studies, what's coming up, what you should pay attention to, and what you can already achieve with these studies. And now we have a bit of lifestyle again. And that's important because I think it's not enough to just say, well, that's one thing we need to achieve, to know what the best therapy is. But then we also have to focus just as much on how to make the therapy possible. In all of this, and that's why both of us place so much importance on showing you these two studies as well, so that you, so to speak, have the opportunity.
What about side effects? We actually had to deal with that, the various side effects of the anti-side effect medication.
That's exactly right, so to speak. We'll have to take another look at that. Some people say there's a bit of drowsiness, yes. And that's why there's the DRIVE study, which investigated this with elinzanetant and showed that driving ability is not impaired, which is very important in this situation. Some people report a bit of fatigue, a bit of drowsiness. Some mention mild gastrointestinal issues. But overall, I have rarely seen these. And these questions of liver toxicity, which you see with WAS, if you're not a breast cancer patient, are also not present here.
Yes, and if I'm taking it in the evening anyway, then drowsiness isn't really such a bad thing.
That is exactly right, I agree. Then I think we are finally moving forward to the very last study of our session. And again, yes, it's a recurring question, and you're right, that's why we've included it in all of this. Can we improve follow-up care? That means if we make it a bit more risk-adapted, if we design it in a more individualized way, better care overall. With a variety of approaches, it's really a whole potpourri without going into detail about everything that was done from coaching to consultation situations in this context, an individualized follow-up care. Not just the examination itself, but especially issues like side effects, lifestyle, and so on. Whether in the control arm or in the intervention group, these aspects were observed along with quality of life questionnaires, etc. More than 15 centers in Germany participated in this. The primary endpoint, of course, was quality of life, measured with such questionnaires, endpoints such as therapy adherence, exhaustion, fatigue, depression, etc., and so on. To summarize, since everyone says I have to do follow-up care, no difference. So even with more intensive coaching, interventions, counseling, and so on, apps, digitalization, whatever, it did not lead to an improvement in quality of life. Overall, but you shouldn't just go along with that, so to speak. I think the table is the most important thing in this situation. That means you have to, as always, really dig deeper. Just saying, yeah, this is all nonsense doesn't help. Instead, we can see on the right, which is highlighted in a reddish color, that we did not improve medication adherence. So more people on letrozole, on anastrozole, on tamoxifen, that's not the case. We weren't able to modify or change that overall because the unintended side effects apparently couldn't be altered. But cognitive issues in all of this, depression, fatigue, so just taking extra care, that's my interpretation. Taking care leads precisely to improvements in the areas on the left: fatigue, depression, cognitive state, and social functioning.
That's really important. So how can you put it? I think it's absolutely wonderful. And that also really serves to emphasize that there's a very urgent and pressing need for action in aftercare.
And that's why, for me, the conclusion is not that the study is useless. The main point, my conclusion from the study, which Professor Würkel from Würzburg also presented wonderfully, including at ASCO, is a needs-adapted concept. In follow-up care, this can have a positive effect on individual symptoms such as fatigue, for example, and depression.
Wonderful. So I generally think there are many areas where we say we need to be more individualized, whether it's about the tumor, about the patients, about seeing the person. That's why I actually think it's a very fitting closing statement that we put the study at the end, because it says so much and will hopefully also lead to consequences. And people shouldn't say that it didn't make any difference, because I think it's just so important. That's why I hope that many of your colleagues will also take this to heart, and everyone who is part of the system, who is involved. Yes, that's basically the final point. Thank you so much, dear Sherko, for always taking the time to explain things so well. Today we had a lot of studies we wanted to present, so maybe at one point or another it was a bit rushed. Nevertheless, the quality didn't suffer. Everyone can download the presentation. We have our written summaries, which you can download as a PDF. Go ahead and share the content and take a look at what everything means. And on behalf of Patients Today and Mamma Mia, I want to sincerely thank you, Sherko, for your explanations, your time, and the enthusiasm you bring. And I'll leave the final word to you.
I can only say thank you. And I even said at Escobar because people said we don't have completely new data now. We have received so much additional information that we can change, implement, and advance starting Monday. And I have to say, medicine is advancing at such a rapid pace right now. It's just wonderful to experience this firsthand. And then it has proven true. When you specialize and have the luxury of being able to devote yourself to this every day, you really can provide so many, let's say, women or even men who are affected with truly individualized top-notch therapies, bringing the best possible treatments right to them. Or even conducting studies where we're already taking the next step, where we can say that what we've discussed today is the result of what we started, let's say, 10 years ago. But with these studies, we're already working here with new medications, making the next advances. And it's not always a step-by-step process like it used to be. Nowadays, it's different. And that's incredible.
This gives so much hope. For me, it's still not moving fast enough, but I'm also a very impatient person. And what none of us have is a lot of time. But I think I love that things are moving forward at such a pace right now. So thank you very much for that.